Hi, good morning, dear colleagues, everyone.
Morning, Kirsten.
Morning.
I welcome you to this video session on managing ICH in the anticoagulated patient. We will talk about protocols and pathway. My name is Thorsten Steiner. I'm a professor of neurology and neurointensive care at Frankfurt and at Heidelberg University. And I have the pleasure to do this session together with Else Sunset, the former secretary of the ESOC. Else is neurologist at the University in Oslo, and David Seifke, who is a professor at Bern University and also neurologist. So, David, if I may put this first question to you. What is the risk of ICH in anticoagulated patients, and particularly in those who are on an anti-factor Xa inhibitor?
Yeah, you know that there's a growing population and incidence of atrial fibrillation in our population because we are aging, so a lot of patients have atrial fibrillation and have an indication to get oral anticoagulant treatment because in general oral anticoagulants are very useful treatment to prevent stroke. But we know from large trials that there is a small risk to have bleeding in the brain on anticoagulants, which is about 0.5% per year in anticoagulated patients. But just because of the growing number of patients taking these drugs, we see these patients coming to our hospitals. And we recently did a merged analysis from the Swiss Stroke Registry together with the Norwegian Stroke Registry. So we have data from two large countries where oral anticoagulant prescription is frequent, and we see that about 20% of all ICH patients coming in are on oral anticoagulants, and we have seen a huge and important shift towards the last years from vitamin K antagonists in the early 2010 years now to the majority of patients being actually on direct oral anticoagulants, or DOACs as we call them, and the majority of these DOACs are actually factor Xa inhibitors.
Can I ask you a question, David? That is, what is the age of the patients in these two registries that you have looked into?
Yeah, so the median age is 78, so it's an older population, which we expect from patients having atrial fibrillation. So they are usually older, they have more risk factors, and I think it's growing and growing that we see virtually only DOAC ICH, or really nearly only DOAC ICH in our hospitals at the moment.
And what is your impression? Do you see an increase in the absolute number of ICHs that are linked to some inhibitors?
Yeah, this was something which was expected in the beginning, because now more patients getting anticoagulants, then we will probably see more anticoagulated ICH patients. But because the overall rate of bleeding in these novel drugs is lower than what we knew from vitamin K antagonists, so the overall percentage of patients with ICH that are anticoagulated remained stable, about 23% during the 5 years that we looked together, that we analyzed in the Norwegian Swiss Stroke Registry.
Mm-hmm. Interesting.
So it is a quite sick population.
It is a sick population.
And that kind of affects our decision making as well when we go on to treat. And when it comes to how do we treat, Thorsten, can you tell us a bit about what options do we have to treat ICH in anticoagulated patients? And do we have any guidelines that can recommend us how to treat the patients?
Yeah, we have, and fortunately we have an ESOC guideline. As we all know, there is not only patients who are on factor Xa inhibitors, but there are other drugs and ways of inhibiting. So actually this guideline also includes vitamin K antagonist associated bleedings. It also includes bleedings that are associated with thrombin inhibitors, and it includes bleedings that are associated with factor Xa inhibitors. And you see there is a flow chart, which I think it's very nice, gives you a very nice overview. And in that flow chart you will find, with relation to factor Xa inhibitor related bleedings, that ESO recommends to use andexanet alpha first, if patients are on rivaroxaban and apixaban in doses that actually come from the ANNEXA 4 trial. Yeah, and that is actually, and of course there is an AHA guideline I should mention, which is actually 1 year younger than the ESOC guideline. But we, as you know, we are on the way of preparation for a next and new comprehensive ICH guideline. Okay. David, there was one thing I wanted to ask you. Can you say something about mortality and long-term prognosis in patients who are on DOACs and have a bleeding?
That's a significant question. So I think from the past data, from what we knew from vitamin K antagonists already, is that this population, as you mentioned, because it's an old population as well, they have a very high mortality. So we know that in the first 3 months there's a mortality something around 30 to 50%, depending a bit on which type of anticoagulants the patients were taking and other risk factors. But the mortality in the population, at least from the data that we have at the moment, is very high. So we have data from example from Norway or from Switzerland, but only from periods where, at least in these countries, specific reversal agents like Adex and Alpha were not available. So these populations are patients that have been treated according to what was available at that time point, which is PCC mostly, at least in these countries. Some patients or some countries actually also use tranexamic acid as topper, but we know that these are not specific reversal agents. So this is what we had available at that time point, and the mortality rates that we know currently with these drugs are based on non-specific treatment. So, but what we have seen, at least in the Norwegian and Swiss population, is that patients who are bleeding on a 10A inhibitor have slightly better outcomes than those who had who bleeding on a vitamin K antagonist. So I think that's already an advantage compared to vitamin K antagonists, but still there is, I think, much room to improvement because mortality is high and morbidity is also high at the moment.
I think we should give the audience an idea about what we are talking when we're talking mortality rate, because it tells us how important it is to have a specific treatment. Any range you could give us on mortality rates?
So what we have seen from the Swiss and Norwegian population, because this is very new data, we just presented it on ESOC, so it's something which is just out there. The mortality rate in patients on factor Xa inhibitor associated bleeds were around 40%.
Yeah, that's interesting, and it will be interesting to have. I mean, there is no randomized controlled trial, as we know, but I think the interesting thing is that in those trials that used reversal agents in these patients, that the mortality was lower compared to those times when there was no treatment. I think, and this is in a range, a significant range, I think.
A question to you, Torsten, then. So with the reversal agents, what are we trying to target? What are we trying to prevent? It's a bit self-explanatory, but I'm asking you anyway.
Yeah, thanks. Yeah, so the problem we have is obviously we cannot make the ICH not had happened. The only thing we can do is we can prevent further increase of the bleeding. And so obviously we need to work on the coagulation cascade, and this is where these drugs interfere with the coagulation system, like factor Xa inhibitor, which is competing with the normal factor Xa in the system, and this is the way how it works.
Then you mean, I think what we are trying to do is to prevent hematoma expansion. Is it that what we are doing?
Yes.
So how important is this hematoma expansion?
Well, we know that patients with hematoma expansion, they do worse and they get bigger bleeds, so they have more increased risk of mortality and poor bad outcome. So, but I mean, for example, with the blood pressure trials in ICH, we have shown an effect on hematoma expansion, but we haven't shown an effect on functional outcomes. So getting from effect on hematoma expansion to translate that into an effect on functional outcome, I think that is, it's quite difficult in ICH patients, because as Torsten said, we cannot change the initial thing that happened. We cannot change the initial bleed, but we can change a worsening. So
then our acute treatment in these patients is a bit different from what we are accustomed to in ischemic stroke, where we go there, go thrombectomy, we recanalize the vessel. Here we are trying to prevent a complication, but we know that this complication or hematoma expansion is very, very important for patients. This is what we can do. And I think the problem a bit when you treat these patients, at least from my perspective, is that you don't see the immediate effect because you're not getting something out, but you're preventing something very important from happening. And so no bad news at the end is very good news for these patients.
Exactly.
I think you are making a very interesting and important point, and that is when we look at trial designs for ischemic stroke and ICH, there is a major difference, and that is in ischemic stroke, it is reasonable to go for improvement. But in ICH trials, what you can do is you can prevent deterioration, and that makes a big difference in trial designs.
Yeah.
I think we should say something about timing. We haven't said anything about timing of treatments. Would you? Either of?
No, I'm happy, and I think there's increasing evidence that time is important in ICH, and traditionally, I think when we see the white blob on the non-contrast CT, we take a step back and go away a bit from we are all geared for the thrombolysis and thrombectomy when the patient comes into the emergency department. But when we see the white blob, we're a bit like, oh, now there's nothing we can do. But I think we need to change this mentality for many reasons why, as you said, with the hematoma expansion, it's bad. We can prevent the patient from getting worse. We can't necessarily make the patient get better, but we can prevent the patient from deteriorating. And we know that the hematoma expansion, it will likely happen within the first 3 hours. So if we want to target hematoma expansion, we need to get to the patients within the first 3 hours, and we need to set time targets also for our ICH patients. So I think we need to change our mentality, and I think both of you probably have experienced, perhaps not so much anymore, but 5 years ago that you saw the white blob on the non-contrast CT, you stand in front of the patient, and suddenly your team of 10 people that is there for thrombolysis and thrombectomy, they just disappear, and suddenly you stand alone with a very sick patient. So I think we need to take what we know from the ischemic stroke protocols, and we need to translate that into our ICH patients, and we need to create protocols where we have clear tasks for every single member in our team on who is doing what, who is ordering the reversal agents for the patients on anticoagulation, who is going to start with blood pressure management. And I think we also see that from the trials presented at this conference, that it is the combined effort that makes a difference for the patient.
Absolutely.
What do we know about the timing of hematoma expansion? So is the hematoma growing when we see the patient in the emergency department? Is it likely that the hematoma grows while we see the patient, so we should be fast and quick with our treatments?
I think, as I mentioned, the hematoma expansion in the majority of patients happens within the first 3 to 6 hours. And I think Rastamal Shai Salman has shown that very nicely in an independent patient data meta-analysis. So if we want to target it, we need to get to the patients quickly. We need to set, we have all the systems in place to get to the patient early and start our treatment. And I also think it does something to our mentality of treating the ICH patients. They are monitored more. They are given a higher level of care if we approach them in the same way as the ischemic stroke patients.
I think you're again making a very important point, and that is we all, I think, have the impression that here things go in parallel, meaning that what we know from ischemic stroke, that there is time is brain, definitely also is indicated for ICH, because for the reasons you just said. Of course you can treat someone in 3 hours or maybe 6 hours, but it is actually the same like with thrombolysis. The earlier you come, the higher is the probability that you do something better for the patient, of course, we do not have a clinical trial that shows this over time, but I can foresee that we will see this result. And so I think we need to be fast, and we have to have similar pathways for ICH.
Thorsten, do you think then we need a door-to-needle time or door-to-reversal time in this moment for ICH patients, as we have it for ischemic stroke?
Yeah, definitely, definitely. Because for the reasons Else was just mentioning, do we need to treat everybody within 3 hours? Of course, we should try to do that, but as we all know, we do not get all the patients within 3 hours. And this is particularly important, I think, in patients who are on oral anticoagulant, because I think there the other reason for hematoma expansion, which is the coagulation, the first one would be blood pressure, the driving force, is there until we haven't normalized the coagulation. And so, yes, it makes sense to even treat patients, let's say, at 4 or 5 hours, as long as the coagulation is not fixed.
Yeah. And I think an important point there is as well, we need to again switch our thinking a bit from ischemic stroke, where we want to save tissue, and we know that time is brain for a different reason in a way. You have the penumbra and you want to open the vessel, you want to reperfuse the tissue, whereas for ICH you want to prevent more bad things happening. You could say you want to do that in ischemic stroke as well, but I think you want to prevent more bad things from happening, and so we should be quick, but it's not as, we don't have the distinct 4.5, or we haven't shown that in clinical trials, the 4.5 distinct time, which is also disappearing in the ischemic stroke, of course. But David, a bit on andexanet alpha. It's not available in all countries, readily available. What is the evidence for using andexanet alpha?
So there's one major study, the Zeneca 4 study, which has been published, which was a single-arm cohort study where all patients with major bleeds on 10A inhibitors were enrolled and received andexanet alpha. And the main outcome was actually the drop-off or the reduction in anti-factor 10A activity, so and the specific anticoagulant activity of the drug. And there were more than 450 patients enrolled in this trial, and a large proportion, more than 300 patients, actually had some type of intracranial bleeding, including subdural, subarachnoid, traumatic, non-traumatic intracranial hemorrhage, cerebral hemorrhage, and I think about 180 patients were those patients that we usually see, non-traumatic intraparenchymal hemorrhage patients. And probably you have seen these publications. So the main outcome was anti-10A activity, and we have seen very nice and clean drops of the anticoagulant activity after infusion of the drug and at the end of the perfusion as well. So it actually does what it should do, so actually specifically decreasing the anticoagulant activity.
But we should point out that the indication at the moment, or the approval, is for rivaroxaban and apixaban only, so far.
Yeah.
Can you say anything about side effects, adverse events in that trial?
Yeah, so of course the trial also assessed clinical outcomes, not only safety but also efficacy. So also hemostasis was assessed, and the vast majority, more than 80% of the patients, actually had good or excellent hemostasis, meaning no hematoma expansion. We in our trials usually define it the other way around. We define the proportion of patients who actually had hematoma expansion, and usually we see about 20-30%, something like this. And if you define it for the Zeneca trial, you have 14%, so very low percentage of patients having hematoma expansion. But of course, if you are treating patients, usually with atrial fibrillation, on anticoagulant, and you give drugs to reverse anticoagulation, you have to be aware of thromboembolic events. You have to register this. Yeah. And there was, at the end of the study, there was a rate of around 10% of patients having thromboembolic events by 10 days. But we have to be aware that this was the entire period, so 30 days after the treatment, and the majority of these, or virtually all of these events, actually occurred several days after treatment. So it's very difficult to determine whether these are treatment-related or patient-related specific outcomes, because I think we all treat these kind of patients. They tend to have have thromboembolic complications. So what are your experience with it?
Well, with andexanet alpha?
No, with this patient population, with a very sick patient population.
No, they are very sick patients,
Yeah.
and that is the biggest worry with these patients. You also stop the anticoagulation for which they have a clear indication, and I mean, I think we've all seen a patient with a hemorrhage, and then you get an ischemic stroke within the next couple of days. It's although it's not, doesn't happen frequently. It happens, and
I think which is very important is that we are now, because we mentioned this trial which has been published now, so which is available, data is available, which provide very promising results. But actually for us as clinicians, as academic clinicians, we would like to see randomized controlled trial evidence. So, are we going to see this one day?
Oh, definitely. I do not. There is a trial, as we know, currently running, looking at andexanet alpha versus standard therapy, and I'm very anxious to see the results from that trial. That will be, I think, a major breakthrough, because it's the first time we have such a big number of patients randomized in these two treatments. But I agree, thromboembolic events, I mean, we are working on the coagulation cascade. It would be not realistic to not expect any thromboembolic events. And the problem is, as you said, how do I define a related thromboembolic event to the treatment? Is it 3 days when we did or is it 30 days? Because you could make the argument, the venous thrombosis started 2 days after the treatment and then became clinically relevant at day 10 or 12. So who knows? That's really difficult.
But you have also stopped the anticoagulation treatment, and that you would do that anyways, and for an indication that they need. So it's a bit difficult, and I think the only way to get this answer is through the randomized trial.
Absolutely.
So I think we all need to get our patients into the NXI trial.
I think, Thorsten, you are the expert because you have run the INCH trial, so the only other randomized controlled trial in such a population. So it must be exciting that we are going to have randomized controlled trial in data in this population one day.
This is why I was mentioning that, because we exactly had that problem to define what really is a related thromboembolic event, and they occur.
Did you see them also in INCH?
Yeah, we saw them, and you see them, interestingly enough, more in the FFP plus PCC. Those were the patients who had the rescued therapy, which somehow would have been expected, because it's the even stronger intervention on the coagulation cascade.
So, Thorsten, this has been an amazing conference for ICH. I think we are leaving this conference with a great momentum for doing ICH trials, and also for the first time perhaps a bit optimism regarding our ability to treat patients with ICH. So Thorsten, what are your highlights, if you want to take home highlights for you?
As you said, we have at least 2 randomized controlled trials that were positive. The one is the INTERACT 3 trial, which looked at a care bundle, including blood pressure treatment, control of glucose, control of temperature, and some of the patients also did receive reversal treatment, though it was only a small proportion of of patients. And that trial was positive. And the other trial was the ENRICH trial, which is a trial that uses a device. It's a neurosurgical trial that uses a device to evacuate the bleeding. Both trials were positive, and you may want to say even more about that. But the nice thing for me, or for us, as we all 3 are in that committee, was that Craig made a point and said, it seems to be the time that there is more and more awareness that ICH needs more support, more visibility, more research. He pointed out that there is an ICH code, a paper written in the United States. There is another initiative, and ESO has taken the chance and has founded an ICH committee. Unfortunately, all 3 of us are in that committee, so I'm very happy with that.
Yeah, and for you, David?
The highlight of this conference, I really much share Thorsten thought, and I think important for us. So Interact shows us that the bundle of care, so taking care of these patients in a structured way, in a specific way with time metrics and clear pathways, is helpful. I think we agree that probably the patient population of Interact is not the patient population that we probably see, but I think the overall bundle of care in this population is very useful and should also should include blood pressure control, but also anticoagulation reversal. And I think the other point for Enrich, so for the surgery trial, I think because we are now speaking about anticoagulated patients, this was a trial where we operate on patients. Now we see that there is evidence that we should operate patients, or should have neurosurgery, and so it's of utmost important that hemostasis is good in these patients. So we have to think about how we could offer more patient surgery by correcting the anticoagulation, so that it comes again to the same point, I think.
And I think if you put the two together, I think we need more trials on surgery. But if you put these two trials together, we can really go home and meet with our neurosurgeons and establish good multidisciplinary teams where we work together to take care of the patients. And I think that is my most important take-home message, is that I want to go home and work even closely with my multidisciplinary team, an anesthesiologist and so on. So really, it's been a great conference for ICH.
Definitely.
This is the right point to come to an end. It was a real pleasure to discuss with you both. Thank you for that. And thanks to the audience. I wish you, for those who are here, I wish you a further nice conference. There will be the plenary session, so have fun.
Thank you very much.
Thank you.
Thank you.
Yes.